let me first introduce who we are talking about this with, though. First, we have Sam Pettyjohn, Health Literacy Missouri. Thank you, Sam, for being here. To Dr. Denise Hooks Anderson, physician and SLU assistant professor. Thank you for being here as well. And Nick Semenkovich, who actually is wearing a different tie. I just consider you a friend.
That's the only part of the outfit that changed, Casey.
That's okay. Yeah, I think the most important part is that you're always sharply dressed and present yourself well. An MD, PhD candidate at Washington University. Okay, so a few things that we've touched on throughout the year. Maybe some topics. We've done shows on almost each of these. Words like access, a phrase like primary care, health disparities. How do those things play into this conversation about the health of our health care?
I think they're a big positive role. We talked earlier in the show about the exchanges and how things have not worked out. You got to remember that's just a fraction of what happens in the Affordable Care Act, right? It's an important part. Insurance is very important, but a lot of the act focuses on things like access to preventive care, access to health literacy. It focuses on things like improving outcomes at hospitals. One thing that worries a lot of hospitals now is that their payments may be reduced if they have worse outcomes for patients, and that's one part of the Affordable Care Act that they're going to look at actually outcomes of surgery and say if your outcomes are worse than the region, we'll reimburse you a little less. So
people keep coming back because they haven't been fixed.
Exactly, and so things like the 30-day readmission rate is what you're talking about. So I think that it's important to remember that insurance is a huge part of this, but there are other huge components of the act that are actually, I think, very good ideas, and we'll see how they work out.
Sure. Some of that getting lost in all the talk about websites and whatnot.
Please go ahead. Well, I was going to say the other issue, a very important issue, is that just because you get this card in your hand, the other issue will be where are those primary care docs to take care of them? Because that's going to be a huge part of that, is that they're going to have more primary care docs for this huge influx of people that are coming.
We have an actual shortage in primary care.
Absolutely,
physician.
absolutely.
And think about how complex it is to be a patient. So just think about the last time you went to the doctor. There's a lot of things you have to do. There's a lot of hoops you have to jump through. Just understanding how your insurance works, understanding the layout of a primary care facility, understanding all the little kind of ins and outs that we kind of grow up with in the medical system. And we have a bunch of people that now have access to care for the very first time, and they're going to be entering that system. There's going to be a lot of questions, a lot of concerns, a lot of barriers for people in that population. And if we don't address those things, we're going to see some really negative healthcare outcomes. We're going to see some major problems in kind of getting the results we want from this act.
I think part of the inspirational thing about these problems is, this gives us a lot of room for improvement. We can address these problems with preventive care. We can address these problems with health literacy. One interesting component of the act is it tries out things called bundled payments. So this was an idea that was started actually many years ago in the 1980s. One of the places that did this was actually the conservative Texas Heart Institute, where when you go in for a heart procedure, rather than paying for every single thing that happens, rather than being billed for the time that the nurse spends and being billed for this procedure, being billed for this imaging, being billed for the CT scan, the entire interaction is billed as one thing, kind of bundled payments of that. And people don't know yet whether that'll be a good thing or a bad thing as these are rolled out, but we're trying them now, and this brings in the idea of, well gosh, if people end up with worse outcomes if they don't understand what's going on in healthcare, that's going to end up costing us money. We're going to have to figure out how to improve education so that we can reduce those costs.
Right.
So there are a lot of cool things in the act that are focused on improving, I think, literacy and access to care.
Definitely. We know that there's a lot of problems with just poor communication between providers and patients understanding discharge instructions. And if patients don't understand the things they need to do to go home to be healthy, to be able to manage their own health, that's where you see a lot of readmissions. And if we're not working to address those things kind of in that hospital environment, in that primary care environment, again, we're going to have some major problems when it comes to getting the patients as healthy as we need them to be for this thing to be successful.
I mean, it can be hard to ask your doctor questions. Now your doctor is in higher demand and has less time to sit and chat. Mm-hmm. It's got to be even harder.
I mean, it's a huge issue because, as he's mentioning, these patients are complex. You got to imagine, if you have not had health insurance for years, I'm sure there are lots of preventive tests you have not had done. There are lots of blood draws. There are all of these different items that we need to cover. Immunizations, certain tests like colonoscopies, mammograms, all of these things that you've never had. So that's very time consuming in a 15, 20-minute visit, trying to get through 20, 25 patients in a day. So it's very complex, and so it's going to take time. It's going to take time to introduce them to the system, to get them used to the system, to understand what does this mean, what does this medication do, where do I go, how do I access this? I mean, I have patients that don't even understand how to get a refill. I mean, they think they have to have their bottles. They don't know that you can call, you can scan it on a phone, you know, that you don't have to just show up to the pharmacy to get a refill.
And are they sold that they need to go to the doctor when they're not hurting?
Oh, absolutely not. I mean, that's a big fight. Trying to teach patients that, you know, you come to the doctor before you get sick. This is preventative medicine. This is what I do. I mean, teaching them that what we're trying to do is prevent disease. So the fact that I'm asking you to get a colonoscopy is to check to make sure that you don't have colon cancer, that if you have that polyp, that we can remove it before it develops into colon cancer. That's a big sale. I mean, I spend a lot of time educating patients on that very aspect of their care.
And that's a much different experience than a lot of these patients have had before. A lot of times these uninsured patients have accessed the system through the emergency room, through a federally qualified health clinic, through a public health department, really where they are sick and they come seeking kind of immediate care. And teaching a patient population to use the primary care system as a preventative measure is going to be a massive undertaking in all of this.
It's going to be a huge change. You know, I've seen patients, hypertension has been a lot in the news this past week as some new guidelines were updated. I've seen a number of patients who are on antihypertensive medications because, you know, they have chronically very high blood pressures, but they only take their medications when they have a crushing headache, when they feel really, really bad. That's the one time they take it, and they come and see you and they start developing complications, and you say, well, what's going on? And they say, well, I don't know, every time I feel terrible, I pop a couple of these pills and then I feel a little better. And I think that we don't do a good enough job of educating people that, you know, this is a preventive care. It takes a while.
So I'm the one that said we were taking politics off the table, so I offer this question in a very apolitical way as possible. But is this very group of people you're talking about getting bigger? We just heard about the lack of Medicaid expansion. Is this group that you're talking about, while you're trying to educate them, actually growing on you at the same time?
Certainly is. There are many people that don't have insurance. There are a lot of chronic health problems in the United States as we progress through diabetes and obesity that lead to a lot of complications. I think the interesting thing that's changed now is there's more of a financial incentive for hospitals and insurers to provide people with more preventive care. Not only is that a requirement as part of the law, but for hospitals, we talked about the 30-day readmission rate. And if they have patients that keep coming back and back for the same problems after they were immediately discharged, they'll lose substantial percentages of their revenues. They actually will cut 1% of Medicare and Medicaid reimbursements. That goes up to, I think, 2% maybe around now. It increases over time. So there are real incentives for both the private parties, the hospitals, the academic institutions to solve these problems, because otherwise it's going to cost them the bottom line.
Well, I mean, and there are other issues as well. I mean, we're talking about, I think, the big picture, but something as simple as copays. I mean, I can refer a patient to a specialist and they'll tell me, doctor, I just don't have the $40 to go see my specialist. I just don't have that right now. I'm like, well, you have this abnormal finding on your CT. You need to see the specialist. I just can't afford it right now. I'm afraid of what that's going to be or something like that. So, I mean, we're talking about the big picture, but the smaller picture, something as simple as a copay.
This has
even
been
the terms we use, I would like to say, just the fact that we call these things all these different things, we call it a copay instead of just a payment you need to make, to pay for your health care in this situation. We have a whole different language around medicine as well as health insurance, and if you're not familiar using that system, that you're going to see some real problems when it comes to be able to communicate exactly what's going on in your body, going on with an insurance system, understanding all the different things you have to do. So until we're able to make the language a little easier for people to understand and relate to, we're going to see barriers there as well.
I remember coming out of college, figuring out, the deductible and then the premium.
Right.
And then I had the fortune of having parents to explain it to me and having the ability to pay for the insurance with the job. But I'm sorry.
Well, you were also saying, look, is this getting bigger? Well, I wanted to bring up the issue just locally. Heathcare closed. And so that was a huge deal. That was our safety net for patients who were uninsured. So patients that didn't have insurance, if you needed a specialist, you could go to Heathcare and could see a gastroenterologist, or you could see a surgeon, or whatever specialty. Now that is closed, where are they going? They have nowhere to go to get follow-up care for a colonoscopy or for an abnormal finding. So that's a huge issue.
So are there things in this law that can help with what we're talking? You touched on it a little bit, but are there things in this law that you think can help?
Well, yes, if they have coverage, because a lot of these patients didn't have insurance. They were mostly going to Heathcare.
Can it help with the literacy as well? Is there something to help you in that battle too?
Well, as long as we need to work on patient empowerment in all of these things. teaching patients the way to better communicate with their physicians, but it's easier in a sense to work from a system level and start communicating with the hospital systems, working with the physicians, the nurses, around best practices in verbal communication, best practices in written communication, offering brochures about quitting smoking that are written at a level that the average person can easily understand. And if we can work to address all these issues, then hopefully we can see a more informed and more empowered patient base that's better able to kind of manage their own care in a sense.
Optimistic? I know you are.
I'm always optimistic. Casey, I think things will work out well.
Oh, absolutely.
Are we moving in the right direction?
Absolutely. I mean, I've always had the attitude that, you know, it's cheaper to prevent disease than to try to take care of it in the end. So to me, it just makes sense.